Okay. All right. So without further ado, I'm going to move forward here. Again, thank you for joining us today. I did want to just give a bit of gratitude here, at the least, for the Administration for Community Living, which is a federal agency that has been quite kind to us in the Memory and Aging Care Clinic at UVA and granted us a significant grant funds over the course of the last several years to conduct a lot of different clinical programs and activities that have really been able to help us support those folks with different neurodegenerative diseases, including Parkinson's and dementia with Lewy bodies. Our agenda today, what we're going to hopefully go over here in the next hour or so is I'm going to provide an overview of Parkinson's disease and dementia with Lewy bodies, or DLB. And we're going to begin by really describing some of the biological causes of both Parkinson's and DLB, and discuss some of the similarities and differences between the different diseases, and then really turn and focus predominantly on what I would call non-motor symptoms of the disease. And what I mean by non-motor symptoms, as we'll learn here in just a little bit, are everything that essentially has to do with cognition and thinking and memory, as well as mood, behavior, and how we're feeling, okay? So first and foremost, this terminology for, when we talk about Parkinson's disease and Lewy body dementia and dementia with Lewy bodies, for anybody who's kind of been involved with this, I think it's fair to say that the language and the words and the terms that get used can actually be quite confusing. A little bit of a word salad, if you will. And what I hope to show you here is that when we talk about Lewy body dementia, okay, that essentially is an overview, kind of a big picture term, an umbrella term, if you will. And underneath that, we see a number of different cognitive disorders or different diseases that are sort of categorized under this larger heading of Lewy body dementia. So for example, Parkinson's disease, Parkinson's disease dementia, or PDD, both fall under this category of Lewy body dementias, as does dementia with Lewy bodies, okay? So again, a little bit of a word salad, but what I'll show you here throughout the next little bit is that even though we can classify, PDD and DLB into different categories, that there's actually a lot of commonalities between the two. So this is, as I was saying, Lewy body dementia is an umbrella term, with dementia with the Lewy bodies on one side, Parkinson's disease and Parkinson's disease dementia on the other. Okay. One of the major differences, just in terms of from a clinical side point, in terms of our from a diagnostic standpoint, if you actually look, you kind of look at what the textbook says, right, is that dementia with Lewy bodies tends to start with cognitive impairment and if not frank dementia. So really early on, when an individual begins to develop symptoms, both in terms of how they're moving and the motor symptoms, they also very early on begin to develop those cognitive and memory symptoms. This is different than what we would typically see in what we would classify as Parkinson's disease with dementia, okay? In the latter, with Parkinson's disease, we tend to see the development of motor symptoms, things like tremor, and then after some time, and we use sort of the 1 year rule here, after about a year of having predominantly just motor symptoms, an individual may then begin to develop cognitive or memory difficulties, okay? So again, by the textbook, what we're saying here is that dementia with Lewy bodies early on, even in that first year of symptoms, we tend to see cognitive or memory problems. But in Parkinson's disease, those memory or cognitive issues tend to develop later. Okay. I'm going to focus a little bit on Parkinson's disease here first. And I'll just show this because we can see some of the history here, which I always think is a little bit neat. So this is the essay on the shaking palsy written by Dr. James Parkinson's way back in 1817. And this is really the first clinical description of what we now know and are calling Parkinson's disease. So quite a formative piece of work here. Today, we have come to know Parkinson's disease and classify it as a neurodegenerative disorder, essentially meaning that this is a disease that's going to affect the body and the brain and get worse over time, and that the symptoms generally develop slowly over many years. So it's not a situation where most folks are going to bed on Tuesday, waking up on Wednesday and finding themselves to be remarkably different. It tends to be more of a linear and slowly progressive disorder. That being said, it's also true that people develop different symptoms at different rates over time. So no two people are exactly the same. Person A may develop symptoms A, B, and C, and person, the next person may develop symptoms, E, F, and G. All right, and those symptoms may come on at different points during the disease, and they may have different levels of severity as well. So the sort of the syndrome, if you will, of Parkinson's disease, we know is quite complex and does vary from individual to individual. The lifespan is also something that varies quite tremendously for different folks as well. Has to do with not just the heterogeneity of the disease itself, but also multiple other factors in terms and sort of including the overall well-being and health of the individual who ends up developing Parkinson's. But on average, there's reports of about 17 to 14 years after the diagnosis. So this is not, again, something that is going to cause, in most cases, sort of this immediate or rapid decline in functioning, or this really sort of short window in terms of mortality. It is common. There are over 6 million people worldwide with Parkinson's disease, and almost about 1 million folks, about 930,000 folks in the US with the diagnosis of PD. It's important to realize that Parkinson's still remains a clinical diagnosis. And what I mean by that is that despite all of our advances in technology over the years in terms of our blood work and genetics and imaging, when it comes to an actual diagnosis of Parkinson's, it's made in clinic by a neurologist, okay? So what's gonna happen is there's gonna be a neurological examination. Hopefully, if you're privileged to have that evaluation done by a specialist, somebody who's trained specifically in movement disorders. And what we're looking for essentially are some what we consider cardinal symptoms. So you tend to think about PD, you think about bradykinesia, and we'll talk about what these are in just a little bit, but bradykinesia being more of sort of a slowness of movement. The classic tremor that you see in most people think of in terms of the Parkinson's. Also some stiffness or muscle rigidity, and in many cases, some postural instability. So that sort of lack of balance, which can lead to multiple things like falls as well. All right, so again, Parkinson's is not made by a blood test or by fancy imaging, but it's made by an expert trained in movement disorders and neurology. One of the things that we're going to look for first is not just do you have those symptoms that I showed you before, but we want to make sure, like, even if you've got that tremor, if you got that slowness, let's make sure nothing else is causing it, right? So we're going to do a really thorough workup and rule out all these other possibilities that could potentially be causing something like gait or balance problems or tremor, right? Because it's not just Parkinson's that can cause these symptoms. We know that there are a plethora of other neurological illnesses, medications, and just a whole list of things that can cause symptoms that look like Parkinson's, but may not necessarily be the case. So we're really going to go forth and make sure that before we give somebody a diagnosis, we're ruling out all of these other causes. Okay. PD itself usually manifests on one side of the body, and that's what we mean by unilateral onset. So in most cases, somebody's going to develop, say, a tremor in the left arm or the left leg, and over time that can certainly move and develop to symptoms on the right side. But at the onset, in the beginning, it's typically going to be a disease where we're seeing symptoms begin on just one side of the body. We're also commonly going to see that classic tremor. And in most cases, or many cases, I should say, you see that early in disease. The vast majority of individuals, even if they don't have tremor initially, are going to develop tremor at some point over the course of their disease. This tremor is what we call a rest tremor, meaning that it tends to manifest when people are, shockingly, right, at rest, which is different than other types of tremor. You know, there are tremors, such as a central tremor, where you tend to see more of the symptom when folks are performing an activity like trying to write. In PD, the tremor may persist when writing, but it actually may remit as well. So we really see that classic resting tremor in Parkinson's disease. As I said before, we know that this is a disease that does progress and get worse over time, okay? And in many cases, though, we see, particularly earlier on, a very good response to medications. I see here this excellent response to levodopa, which is usually a kind of a first-line course of medication for many individuals with Parkinson's disease. So one of the ways that an individual, or a clinician, I should say, can develop a higher confidence that what we're actually looking at is Parkinson's when we're trying to make that diagnosis is to say, you know, are we seeing symptoms on one side? Is the tremor maybe happening at rest instead of during action? And if we do a trial of medication and we see improvement, that increases the likelihood that we're looking at Parkinson's disease. We also see that the medication response, you know, particularly if it lasts for a longer period of time, increases confidence. And then again, these symptoms are going to persist. They're not just going to sort of spontaneously remit or go away. In terms of the cardinal symptoms that I was referencing earlier, that, you know, what we mean by bradykinesia is really that sort of reduction in automatic movements, you know, really is sort of a slowing. So, you know, when an individual is walking and sort of how they're swinging their arms becomes a little bit less fluid. Blink rate can also become, you know, less rapid as well. So difficulty sort of initiating movements, rising from a chair, and essentially just thinking of bradykinesia as that generalized slowing in physical actions and movements overall. The rest tremor, as I said before, is something that occurs when folks are non-active. It can certainly cause people some difficulty when they're trying to fall asleep, but when they are asleep, it tends to go away. And again, this also tends to affect one side of the body, although later spreading. You know, notably, we hear this from just about everybody, is that when you're under some undue stress, anxiety, if you're tired, even if you're trying to focus or concentrate harder, we can really see an exacerbation or a worsening of the tremor symptoms. So, you know, it's this common thing where we always say once the juices kind of get flowing, it can make things a little bit worse, which can certainly be quite frustrating. I want to take a second here and just kind of quickly talk about dyskinesias. And I want to do that because I want to make the point here that one, you know, just in terms of defining them, and the dyskinesias themselves are what you tend to see of these sort of fluid or dance-like movements. I'll also often tell folks that if you've seen the older videos of Michael J. Fox on, you know, on TV when he's giving interviews, a lot of the movement actions that you often see when he's giving those interviews are what we would call dyskinesias. But interestingly, and I think importantly, it's these movements, these dyskinesias are actually a side effect of medication and not a symptom of the Parkinson's itself. And I can show you what I mean by that. So if we look here in our slides, I'll try to walk you through this a little bit here. It can be a little bit busy, but if we look at this sort of the blue window here, this is sort of early stage Parkinson's disease, okay? And this blue line is sort of going to be where we have our dopamine, which is sort of naturally produced as a neurotransmitter or a chemical in the body, okay? The natural dopamine. And then so you can give levodopa or Sinemet, again, one of the common medications to treat the loss of dopamine that we tend to see in the disease. And if you have the right amount of medication, the right amount of dopamine in the body, in the bloodstream, and it's sort of staying within this overall blue window, that means we're having a pretty good effect of the medication. It's doing what we want to do, and we're sort of in this sweet spot, right? Really think of this blue window here as the sweet spot. What can happen, though, is over time, you see that this blue window has begun to shrink, okay? And when we have that medication, again, this blue line that's going up and down here, we give the medication, and right at the top here, we end up having a little bit too much medication or a little bit too much dopamine in the bloodstream. It's pushing outside of this sweet spot. And that is where you can see the dyskinesias develop, this movement or fluid-like symptoms. So you get this short period of time, you know, in that middle stage often where you have these dyskinesias. And then as the medication begins to wear off a little bit more, we go back into the sweet spot and we're okay. You know, we have one of these dots here, which represents another dose of medication. Maybe we're okay. And then we come down here, and if we dip below, if we dip below the sweet spot, that's when people can feel quote unquote off. They don't have any medication in their body. They feel rigid and stiff, and it can be quite hard to perform many activities. Take a new dose, and then again, you're doing well for a while, but too much medicine can cause these dyskinesias, and you have a little bit of that up and down throughout the course of the day. In the later stages, we can see essentially the same thing, but again, we see this shrinkage in the sweet spot. We have more sort of ups and downs, more periods of on and off medication, where when we're on, we're sort of got too much going in and we're got these dyskinesias. And then when we're, you know, dropping down, we have these periods of off. So that time that the medication is working, again, that therapeutic window, as we would call it, begins to shrink as the disease progresses. Okay. All right, I want to switch gears here kind of slightly. That was sort of kind of the 101 course, if you will, of Parkinson's disease. And I want to turn a little bit to dementia with the Lewy bodies as well. Like Parkinson's, this is also a neurodegenerative disorder. And although I don't think it's quite in sort of in the public's eyes as well known, if you will, public or media for that matter, it is an incredibly common cause of dementia, okay? It is twice as common in men than in women. Parkinson's as well is more common in men, but it tends to affect people at a younger age than Parkinson's does. As with PD, and really as with any of our neurodegenerative disorders, and this would be the same for Alzheimer's or otherwise, the incidence, meaning how many times or how the number of people that are developing this particular disease at any one point in time increases with greater age. So, really more than anything else, age is by far the biggest risk factor for developing a neurodegenerative disorder, developing dementia, or cognitive problems, regardless of the disease that you're talking about. DLB tends to be a more kind of rapidly progressive disease. And not only is it affecting folks typically at a bit of a younger age than Parkinson's, but it also sort of has a shorter lifespan than Parkinson's as well. It does range. There's quite a lot of variability as we see in PD, but really the lifespan tends to be, as reported, somewhere between 5 and 8 years after symptoms begin. As I was alluding to earlier, one of the major differences here between Parkinson's and DLB is the fact that we are seeing the cognitive problems that really develop early on in this disease. And they tend to be problems in things like attention and executive functioning and visual abilities. And we'll talk in just a little bit more, a little bit later in this session here about what I mean by executive functioning and these visual abilities. We'll break that down a little bit. But the point here now is that in most cases, we're seeing these changes in cognition or thinking that are not necessarily memory early on. And as the disease progresses, it's certainly quite common to develop more severe problems in these same areas that we had the early dysfunction, but also to develop additional problems in areas like memory and language. But there are going to be, while there's some overlap, there's certainly going to be some differences in presentation as to what you might see in other neurodegenerative diseases such as Alzheimer's, where that classic memory or amnestic profile is something that is really typical early on. When we are making a diagnosis of DLB, we are also looking for some cardinal symptoms, again, just as we were with Parkinson's. these symptoms really are, two of these three that I have here. So classically, we see what we would call a fluctuation in attention or alertness, okay? So in many of our neurodegenerative diseases, it's common to have good days and bad days. We hear that from families all the time, but with DLB, that tends to be a little bit more significant. So it's not just having good days or bad days, or good weeks or bad weeks, but even within a day, sometimes within an hour, we can really see more significant ups and downs. It can be described in many different ways, but you can think of an individual as almost sort of being with it and attentive and sort of engaged at a particular period of time. And then somewhat abruptly, they seem just a little bit out of it. They're not exactly comatose by any stretch, but that engagement and sort of that sense of being locked into the environment around them, the people, the conversations around them, that dissipates. So there's really this up and down in terms of somebody's attention and concentration and alertness that can shift again throughout the course of a day or even within shorter windows during that day as well. One of the other common things that is really classic for DLB is visual hallucinations, okay? So these tend to be recurrent and fairly well formed. And then they also tend to begin pretty early on in the disease. Now, with many of our other neurodegenerative diseases, Parkinson's and Alzheimer's, it's certainly not uncommon to develop hallucinations. But again, in those other diseases, this is something that would happen more commonly later on in the disease course, where we see it being one of those earlier cardinal symptoms in DLB. And then as with Parkinson's disease itself, we also see motor symptoms. So DLB is going to be this disease that is characterized early on by both cognitive changes, cognitive attention, perhaps memory problems, visual hallucinations, but also changes in how somebody is functioning from a physical standpoint, from a motor standpoint. You get a little bit of that non-motor and motor symptoms early on in this disease. There are also symptoms that can occur and often commonly do occur in DLB that you don't necessarily need to be there in order to make a diagnosis, but they're common. And if they are present, that increases the confidence that a clinician might have that what we are in fact looking at is DLB. These are suggestive clinical features, and they include what we call REM sleep behavior disorder. And what we mean by this is when somebody who is healthy, cognitively healthy, neurologically healthy, when we're going to sleep, we tend to move through different stages or levels of sleep. Starting off perhaps in like a more shallow stage of sleep, but we kind of cycle through more deep sleep states to shallow stages of sleep, and we kind of go up and down through that throughout the course or duration of our nighttime sleep. When we're in that deep sleep, or that REM sleep, if you will, what your body's actually doing is it's sort of becoming rigid. You tend to be locked in, for lack of a better word. Okay, when you have REM sleep behavior disorder, that sort of natural kind of lack of movement or locking in goes away, and we can see some quite significant movements, upwards of even more severe thrashing about in the middle of the night, punching, kicking, knocking over lamps, kind of striking even bed partners. So these can be mild sleep behavior disorders, or again, quite significant. But individuals who do have REM sleep behavior disorder have a much higher likelihood of developing DLB down the road if it's not already diagnosed. We also can see what we call severe neuroleptic sensitivity, which is also another way to say neuroleptic, meaning antipsychotic medication. Okay, there is just greater side effect profiles that individuals with DLB have to antipsychotic medication than those with other neurodegenerative diseases. And there are some imaging signs. So there's these kind of neuroimages, that we can take, similar to an MRI, but slightly different in terms of what we're actually using, the technology for the machines, and what we're actually looking at for a SPECT or a PET scan. And essentially we can look to see how much dopamine is in the basal ganglia of the brain, really in the brain overall. And if there is not as much as we might expect for somebody, given their age, that again increases the likelihood, or at least the possibility, that we might be looking at DLB. Certainly if those other more core clinical features that I showed you earlier were also in place. Okay. All right, and I showed you this before, but I'm going to put it up again though, because I just went through kind of two sections of this where we talked about Parkinson's disease and we talked about DLB. But again, I want to say, despite the fact that these are talked about as sort of two different diseases, you can still really think of them as almost being on a continuum, right? They both fall under this category of Lewy body dementia, and there's a lot of similarities between the two. And the reason for that is because some of the underlying pathology, the actual disease itself, from a biological standpoint, that causes both DLB and PDD, there's a lot of overlap and similarities there. We don't call it, the Lewy body dementias for no particular reason. Lewy bodies is really the hallmark pathological feature of Parkinson's disease. And essentially what we're looking at here, and you can see in some of these slides, we have this abnormal buildup of proteins in the neurons. So within inside each of these neurons, there's this protein that really shouldn't be there. And that protein itself is made up of what we would call phosphorylated or misfolded alpha-synuclein. So both Parkinson's disease and dementia with Lewy body are part of a broader class of diseases that we know of or think about as being related to alpha-synuclein, or what we would call synucleinopathies. So that shared pathology, the disease itself, the fact that there's similarities there in the brains of both individuals with DLB and PD is why we see so many of the clinical symptoms have overlap and similarities as well. And you can see that in these next two slides as well. Now, if you look on the left here, this is the substantia nigra of an individual with sort of a normal, healthy individual. And you see these two areas where there's this purple pigmentation. That purple pigmentation is completely normal. That tells us that there's a good amount of dopamine, again, that chemical that we need to move and to think clearly. There's the right amount of dopamine in the substantia nigra in this section of the brain. But on the right of this individual with Parkinson's disease, we see that there's that loss of purple pigmentation, and that represents the loss of dopamine, right? So without the dopamine, we can't function normally. And we see something quite similar, again, but this is with a patient with dementia with Lewy bodies. So we see here that there's this loss of pigmentation, right? But in healthy individuals, it's more full and purple. So two different diseases, but again, overlaps in terms of the loss of dopamine, which again is related to how and why we see some of the symptoms that are similar in both diseases. All right. So I want to turn my attention now to, again, what we call non-motor symptoms. Now, hopefully I was able to provide a bit of an overlay as to what the cardinal sort of motor features of the disease were and some of the underlying pathology that causes these diseases. But we really want to focus here on non-motor symptoms being psychiatric and cognitive and memory symptoms. And this is important for several reasons. One, we know that these non-motor symptoms are extremely common in both diseases. As a matter of fact, if we think about these diseases in their totality, it makes sense to really think about them being comprised by a constellation of symptoms that in most cases comprises non-motor symptoms, right? So the majority of people with Parkinson's are going to develop non-motor symptoms. And by rule, with dementia with Lewy bodies, because cognitive impairment is part of that diagnosis, at least everybody's going to have at least that cognitive difficulty and oftentimes hallucinations and some other cognitive and psychiatric problems as well. So when we talk about non-motor symptoms from the 30,000 foot perspective, a host of different symptoms that we can list here. We see things like a loss of smell, either in its entirety or certainly to a significant degree. We've already talked about REM sleep behavior disorder, which is quite common in both disorders, but there can also be other types of sleep difficulties, including daytime sleepiness and difficulties with sort of sleep maintenance. So some folks might have difficulty initially falling asleep when they go to bed. Others may be able to initially fall asleep, but have difficulty remaining asleep throughout the course of the night. We also see a range of other autonomic symptoms. This includes things like constipation, urinary urgency or frequency, and certainly orthostatic hypotension is a quite common symptom that we see in these diseases as well. Other common non-motor symptoms, and some of these we'll really focus on here, both in this lecture today and in our sort of second and third part lectures coming up in the following weeks, are psychiatric symptoms and then cognitive and memory symptoms. Psychiatric symptoms include anxiety, depression, apathy, psychosis, which we'll talk about, as well as mild cognitive impairment and dementia. So all of these range in terms of how severe they manifest and actually even just if they manifest in a particular individual. So again, it's a bit of a mixed bag in terms of who develops which symptoms and how bad they are. We focus on this because not only is these are common symptoms of disorder, but they really are the most significant symptoms when it comes to determining the overall quality of life for both patients and caregivers, okay? So essentially, if you take, and then a lot of good research and science behind this, if you take two groups of people with Parkinson's or DLB, doesn't matter, and each group has the same motor symptoms, the same amount of tremor, the same amount of difficulty walking or moving around, and one group has cognitive problems and the other doesn't. The group with cognitive problems is almost certainly going to have worse quality of life and greater disability than those without the cognitive symptoms. And the same can be holds true when you think about things like anxiety and depression as well. These are really the biggest drivers, these non-motor symptoms, right? These are the biggest drivers of overall well-being, and again, both patients and their families. So critically important for us to think about, not just in terms of, recognizing that they're there in the disease, but making sure that we're doing accurate and assessment, repeated assessment for these symptoms, and making sure that we're treating them to our fullest so that we can remediate the symptoms and improve overall well-being. To show you what I mean here in terms of these symptoms, anxiety, just break this down a little bit further, can be experienced in upwards of 40 to 60% of individuals. And this is importantly not just the reaction to the disease, but a symptom of the disease itself. And what I mean by that is I think quite commonly we can see folks who might show up to clinic or might talk to their families and say, I'm feeling a bit nervous, I'm feeling a bit anxious, I'm worried about my symptoms, I'm worried about, what's going to happen to me in the future. Quite common, quite understandable, okay? So that nervousness that a particular individual feels can be related to, again, what's happening in their body today and what's going to happen in the future. But there's also changes in the biology, right? There's changes to different chemicals in the brain and different circuits in the brain that are tied to how we feel and how we behave and are tied to anxiety. So when those circuits begin to go a bit awry, we can also see anxiety develop, again, from a direct standpoint of how the brain is changing. So it can be that reaction to the symptoms as they happen, but can also be directly because of the brain changes themselves. We also know that there is quite commonly folks with anxiety experience other psychiatric symptoms like depression. And this mirrors what we see in the population at whole as well, is that in sort of otherwise healthy individuals and sort of a more classic psychiatric population, there's a very high correlation between depression and anxiety. Even though they are different constructs and different sort of disorders in and of themselves, they quite commonly co-occur. Anxiety in PD can really look different for different folks. Some individuals really develop more of this, what we call a generalized anxiety disorder. This is meaning that we tend to worry and become nervous about this, that, and everything, right? They may be focused on their health, but that's not the only thing that causes anxiety. It just tends to be more widespread and more pervasive. Other individuals don't have that generalized anxiety, but it's more circumscribed, panic attacks. We get really nervous in particular situations, whether that's social settings, or if our medication is wearing off, or even if it's not, and we're fearful that our medication might begin to wear off because we know how difficult that makes our lives. That can actually induce not just anxiety, but a full-blown panic attack. On the spectrum of anxiety, we also see what we call obsessive compulsive disorder. And even if you don't have the full-blown disorder, we can see more of sort of obsessive and compulsive symptoms. So this can be anything from checking behavior to other types of kind of ruminative thoughts that go beyond sort of classic anxiety. So a range of anxiety symptoms that individuals can develop. Depression is much the same way. At least I'd say 35% of folks have what we'd call clinically significant depression. On the more mild end, this number would actually be higher. There's a lot of individuals out there that are going to develop, mild, sometimes, fleeting, maybe not fully consistent symptoms of depression, and maybe subclinical depression at that. But then this can certainly become worse for some individuals to the point where people meet criteria for major depressive disorder. Just like anxiety, depression can be a direct cause of the biological changes in the brain, all right? Those circuits that are coming, offline, those chemical changes that are occurring in the brain. And it can be an indirect result of the disease itself. So as, folks see a progression of the disease, greater limitations posed on their independence and functioning, that can cause certain and understandable frustration, which can lead to periods of sadness, if not outright depression. So again, direct and indirect results of the disease can contribute to both anxiety and depression. Apathy is also quite common, though probably less talked about, unless you're somebody that happens to be an individual with one of these diseases, or maybe more so even their family member. Apathy occurs upwards of perhaps 60% of people in some studies. And what we mean here is really we're talking about that really classical loss of motivation or interest to engage in activities. So this is fundamentally different than just being lazy. And I hear that all the time. This person just doesn't want to get up. They're watching TV all day. They're lazy. They don't want to do their chores. They don't want to go and even see family or friends. And what tends to happen though is if they get the right amount of encouragement, right? They get kind of pulled up or they get started with a particular activity, then they're happy and they can keep going and they can keep engaged. It's just that sort of initial get up and go that has often got up and left, right? So motivation to start activities, to perform what we would call goal-directed tasks, or engage in our responsibilities, that is also hardwired. And there are brain regions and brain circuits that are responsible for telling us, hey, it's time to go do something, even if it's something pleasurable. And when those circuits are not working well, we do not sort of self-generate those activities. So much in the same way as cognitive impairment or depression or anxiety is not the fault of an individual with Parkinson's disease, neither is apathy. But it is quite common, and it can be quite frustrating, particularly for caregivers, because this individual doesn't, they're not depressed. It sort of coexists oftentimes with depression or cognitive abilities, but it is fundamentally different than depression. It's not that lack of happiness, or it's not, crying or sadness. It's just, again, more tied to a pure loss of motivation. In both Parkinson's and DLB too, we can see again this range of what we call psychosis or psychotic symptoms, okay? As we spoke about, particularly the visual hallucinations are quite common early on in DLB, and more common later in the disease course for folks with Parkinson's. Importantly, these symptoms, while they can be disturbing for some individuals, oftentimes they're not. So it's important to realize that just because a symptom is present and that we can see it as clinicians or as family members, and it might seem, even quite strange or disturbing to us, it doesn't necessarily mean that that's the case for the individual who is experiencing them. So where that becomes really important to keep in mind is from a treatment perspective. We have a lot of individuals that we see in clinic who have pretty significant hallucinations or other psychotic symptoms, but they're not distressing, they're not disturbing, they're not harmful or a safety risk in any particular way, which means we have to be less aggressive, or we have the opportunity really to be less aggressive in the way that we approach treatment. We don't need to necessarily throw a whole bunch of medications at an individual if the symptoms themselves are not disturbing. So not just getting a sense of if a symptom is present, but how distressful they are is quite important. Psychosis is itself on a continuum. We talked about visual hallucinations. Quite commonly, folks will see things like small animals or people, either in the room or outside, that are not really there. To be a hallucination, these are sort of well-formed figures. A person actually sees that other individual or sees that animal. But they can be sort of a little less well-formed than that as well. And sometimes we see, or folks will develop what we call visual illusions, where it's not quite a frank hallucination, but they're still seeing things that may not be there. It might be flashes or shadows or movement. Oftentimes it comes out of the corner of an individual's eye. They tend to be fleeting. So they're still seeing things to some degree that are not necessarily present, but it's of a different degree than would be a sort of a well-formed hallucination. Individuals can also have what we call presence hallucinations or passage hallucinations. And here we can really see where an individual feels like somebody might actually be in the home with them when they're not really there. There's sort of this presence, somebody behind them or in the room. They're not necessarily seeing them, but there's just that strong sense that somebody is with them when it's not necessarily so. Okay. Right now, I would normally take questions, but we're doing this on the virtual format, so I'm going to keep going and take questions at the end here. I'm going to switch gears a little bit from the psychiatric features to cognition, okay? We know, as we said, that cognitive impairment is really common in both of these disorders. Particularly in Parkinson's here, you can see, we do get the range. There are individuals with Parkinson's who have no cognitive impairment, some who have what we call Parkinson's disease with mild cognitive impairment, or MCI, and then those with more significant cognitive deficits that would meet criteria for dementia. And then there's sort of everything in between, right? Mild cognitive impairment is present in about 15 to 30% of patients at the time of diagnosis, okay? Excuse me. I say that to mean that we, early on, we want to be looking for cognitive issues, making sure we're sort of thoughtful and assessing the full range of symptoms that can present in the disease. Quite commonly, folks are going to show up to their doctor because they have a tremor. And a lot of the focus can be specifically on that tremor or problems with walking, falls, and rightfully so. But we don't want to focus on that at the exclusion of other important symptoms like cognition. So, if 15 to 30%, somewhere say about a third of people have a mild cognitive impairment, again, around that time of diagnosis, so this would be early on, it's clearly important for us to be paying attention to that so that we're creating treatment plans and sort of structuring both from a medication and a non-medication standpoint, ways that individuals can, be successful in their lives and remain independent and really successfully cope with and work around the cognitive issues as they manifest. 10% of folks with Parkinson's are going to develop dementia over the course of a year, okay? Such that a third of folks are going to have, at any one point in time, have dementia. So really, and I said this earlier, right? If you think about an individual, any one person who has Parkinson's disease across the period of their own lifespan, again, the biggest risk factor for developing cognitive problems, developing dementia, is going to be age, right? So if folks live long enough, there is a much greater likelihood that they're going to develop dementia. Over 10 years with Parkinson's, there's about an 80% chance of developing PDD. Okay. I'm throwing these terms out a little bit in terms of MCI, mild cognitive impairment, and dementia, but I do want to just stop and make sure that we're all on the same page here in terms of what that means. Okay. Both mild cognitive impairment and dementia, by definition, mean that we're looking at something that is not normal aging. Okay, and that's important because we do change as we get older. We do have increasing cognitive and memory problems as we age. But there is a fundamental difference between the changes that we experience just by getting older and what we mean when we are looking at MCI or dementia, okay? One of the biggest factors that differentiates whether somebody meets criteria for MCI or dementia is the severity of their cognitive impairments, which we can measure on our testing. But also importantly, if not even more importantly, it's the impact that those cognitive issues have on that individual's day-to-day life. Okay, so we can look at what we call basic activities of daily living, things like eating and bathing and dressing, really self-care activities. All right, when these self-care activities are preserved, we are certainly not looking at mild cognitive impairment. And there's also what we call instrumental activities of daily living, which are, as opposed to the basic self-care tasks, dressing, these are the more complex tasks that most of us do throughout the course of the day. Managing the household, managing bills and finances, driving, managing medications. When an individual has problems, more significant problems in these day-to-day activities, okay, that is when we really start thinking that we've crossed the threshold from mild cognitive impairment. So most folks with MCI, may have cognitive complaints. They may feel like they're getting worse. And we can usually, almost always assess those, measure those cognitive concerns or changes on our testing. So they're there, they're real. The person's cognition and memory isn't quite what it used to be, but it's not so bad that it's substantially getting in the way of their day-to-day life, okay? So that would be what we'd see for MCI. As soon as it really starts to more significantly interfere with day-to-day activities, then we're in a mild cognitive impairment strategy. And then as time goes on, if we really start to see the impact of these more basic self-care activities, now we're moving in more from a mild dementia stage to a moderate to severe dementia. So we really are focusing on the impact of cognitive changes on day-to-day function. Cognition overall is, again, think of cognition as sort of thinking abilities, certainly not one thing, right? So there's lots of different, what we call cognitive abilities and really cognitive domains. In both Parkinson's and DLB, we can see these early changes in what we call executive function, right? So kind of a term, sort of another umbrella term that we use to describe higher level, kind of more complex head to making decisions, to kind of holding something in your mind while you're doing something else, being able to inhibit your actions or your words, kind of self-control, if you will. Again, more complex cognitive tasks. And these are often affected quite early on in both disorders. Other cognitive abilities that we see are perceptual, or you call them visuospatial abilities, our ability to sort of see the world around us and navigate successfully. And this is not just seeing from like the lens of, how well your eyes are working, right? We're not ophthalmologists here, but we're thinking about how the actual visual centers of the brain are working. And this would tie into all kinds of different day-to-day activities, even such as, driving and navigating. It allows you to sort of understand where you're going on the road and how you're getting from A to B. Issues with attention, as we talked about, are common. So being able to sort of keep your focus or your concentration for periods of time, this can often be diminished in both disorders. And you really can see that fluctuating attention, sort of that up and down quality of attention or alertness in the disorders as well. Language is another cognitive domain that tends to be less affected, particularly early on in both DLB and PD. So, most folks as they're getting older have some degree of word finding difficulty. But in some of our other disorders like Alzheimer's disease, that characteristic language deficit, that word finding deficit is really classic for something like Alzheimer's. And it's not something that we often see as a primary symptom in either the Parkinson's or DLB. And then I'll just talk quickly here about learning and memory. We'll go to this in a second here. But as I said earlier, learning and memory is sort of a complicated cognitive process that the brain goes through. And although aspects of it can change in both of these disorders, it's not going to happen in the same ways you might see again in something like an Alzheimer's disease, where it's more of that very frank amnestic profile, where there's the lack of ability to consolidate or store information for longer periods of time. So I went through this just a second ago, but I just wanted to kind of typify again here. Executive functions, again, multiple different types of abilities that fall into this category. Flexible thinking, impulse control, self-monitoring. Again, all of these abilities are sort of prime targets to be impacted in both PD and DLB. Attention itself, I was saying, is not one thing. So when I think about attention from a sort of a neurocognitive perspective, we're looking at from a sort of a basic standpoint up to a more complex level. So we see that sort of if somebody has an initial attention, can you, what are you going to attend to? If a loud boom goes off, and you sort of listen to this talk and a loud boom goes off outside, are you going to then sort of turn your attention to that and return back to the lecture, or are you going to have your attention remain sort of distracted over a period of time, right? So it's what are you attending to sort of in the moment? What can you focus on? You sort of actively and consciously choose to focus on and pay attention to. And then after you've made that choice to focus on a particular task or conversation, can you hold that focus for periods of time, right? Just a little bit of backdrop there in terms of what we're looking for and when we think about attention. And I'll just show you that this plays into learning and memory. I think as I was saying, that memory per se may not be the first thing that's affected in these disorders, but I will tell you that despite that being true, quite commonly we often see very significant memory complaints in these individuals. And that's because we might see interference in other thinking abilities that can essentially kind of produce or lead to problems with what looks like it's memory. And I'll just show you what I mean by that is that I would say that the first part of memory is actually not memory at all, but it's attention. You have to be able to pay attention to something if you ever hope to get it in, which is what we call this sort of encoding phase, right? You have to be able to pay attention, focus on something if you ever want to get it into your head, get it into your brain in the first place. Once you go, you go forward and you're sort of taking in that information, your brain then has to be able to store it or file it away. And then later down the road, you need to be able to pull it out. So this memory process is, again, it's more than one thing. It's a little bit more complicated than we might like to think it is. And it can be that individuals have problem on the front end here, being able to pay attention or be able to more efficiently take in or learn new information. And you can imagine that if you're having trouble attending to or learning new information, there's going to be less there for you to pull back out down the road. So that might seem like a memory problem, but in fact, you're not actually losing information over time. It's not a failure to file it or store it away, as you might see in Alzheimer's disease. It's just harder to get in the first place, right? So some cognitive deficits, like problems in thinking speed or efficiency or problems in attention, can also give you a little bit of a double whammy and produce other difficulties, such as kind of get in the way of those memory functions. Okay. I talked a little bit before about visuospatial abilities here. Can really interfere with things like navigation on the road. Okay. The question then, though, is sort of, well, what do you do? Not just from a memory standpoint, but overall. A full talk here on sort of the treatments of Parkinson's is going to be beyond the scope of what we can accomplish in this particular lecture. But I think it is important to underscore that although we don't currently have a cure for Parkinson's or a cure for DLB, that there are certainly treatments that are important and have been proven effective in improving symptoms, both motor symptoms and non-motor symptoms, and improving overall well-being and quality of life, which is clearly a target. So these are things from levodopa, classic medications. Antidepressants certainly work in a number, the majority of individuals, and trying to treat things like anxiety and depression. There's medications, I'll show you in a second here, we call them cholinesterase inhibitors, that can be effective in certain cases in terms of stabilizing cognition, kind of holding folks in terms of their thinking abilities, holding them where they're at for longer periods of time. In Parkinson's, we can see effects of deep brain stimulation. If medications begin to lose their efficacy over time in many individuals, that can be a reasonable surgical alternative to improving the motor symptoms. And then there's other sort of newer treatments such as like Duopa, which is essentially still trying to get that medication, that dopamine medication into the body, but instead of like a pill form, we're going to do that through a pump that is sort of directly goes into the intestine. So there are treatments for Parkinson's disease. Specifically, again, on the cognitive side, because we get this a lot, those cholinesterase inhibitors, rivastigmine is FDA approved for the treatment of cognitive impairment, and specifically the treatment of dementia. Other medications have been tried. Essentially, what I say here is there isn't this scientific sort of footing right now to suggest that we can use things like cholinesterase inhibitors earlier on in the disease, in the sort of the subjective cognitive problems or mild cognitive impairments. So we don't really have much of a treatment at that stage. But if folks are progressing to more significant cognitive difficulties, meeting that criteria for dementia, there are options out there for a number of individuals in terms of medication and trying to hold people's cognition, hold their memory and day-to-day functioning where they're at, preserve their functioning for longer periods of time. And then, importantly, and I could give you 100 slides on this and probably still not be content, but I'll control myself and give you one. You can do a lot. We tend to think about treatments as being something like medication and surgery, but I will tell you that the science is unequivocal. It is absolutely clear that there are a host of things that you all have within your control that have a significant impact, not just on, how you feel in this sort of global or, ambiguous sense, but they affect how you walk, they affect your motor functioning, they affect your mental health and well-being, your overall quality of life, your disability level. Folks that exercise, have a good regular physical exercise regimen, certainly just do better, period. They're physically more healthy, they're happier, they live longer, okay? Good diet, staying socially active and cognitively engaged is incredibly important. It is, again, clear that if you look at groups of folks who are watching television all day versus folks who are volunteering, who are working, who are engaged in activities with their friends and families, those who are engaged do better. And that's just how it is. Sleep hygiene is also very important. When your sleep goes awry, that can essentially throw everything off kilter. It can, not just cause fatigue throughout the day, but it can get in the way of cognitive functioning and memory. It can cause or increase at least risk for things like depression. It can really just throw things off kilter. So making sure that we've got a good sleep regimen is really important as well. And then there are resources out there. So you're not alone. There are a tremendous number of really amazing organizations out there that provide not just a plethora of information and educational materials, but also access to other clinical trials, access to support groups for both individuals with Parkinson's or Lewy body dementias overall. There's just a few on here, but these are, I think, really wonderful resources that I would encourage anybody to explore if they haven't done so already. And then you're not alone here from a clinical perspective. You know, we're giving this lecture here, again, on behalf of the grant funding that we had from ACL, but was really part of a larger initiative from the UVA Memory and Aging Care Clinic led by Dr. Carol Manning. And you see other members of our wonderful clinical team here as well, Tanya Pratcher, Dr. Ellie and Fuchs, and myself. And just a host of other individuals, both on the clinical and the clinical research side, that are really here to support patients and families with these particular disorders, as well as the individuals in the Parkinson's disease and movement disorders clinic, including Dr. Harrison and Shaw, Dr. Dalrymple, amazing nurse practitioner, Bridget Moss. I apologize, neither of those two have pictures available, but they need to be recognized anyway. And then Dr. Elias, a neurosurgeon who performs our functional neurosurgeries for individuals with movement disorders. Okay. All right, and on that note, I'm going to stop here. Thank everybody for your time and for joining us today. I am going to open this up for some live questions for those who have joined us. And again, for those who weren't able to join us today, that's okay. If you're hearing this, that means you're listening at another time. So I appreciate your time as well. Thank you. Okay, I have allowed sort of folks to unmute themselves. So if there is anybody on this call right now that would like to ask any questions or have any sort of follow-up thoughts, I'd be more than happy to do that with individuals. Just unmute yourself and feel free to jump in with a question. Okay, if there's no questions, then I'm going to say thank you again and let everybody go for the afternoon. I hope you have a wonderful day. Take care.